In the next section of our physiology review, we're going to introduce the concept of airflow, basically understanding how air moves in and out of the lungs, and especially how that air can be obstructed, creating problems in the diseases such as asthma and COPD. In the next section, we're going to talk about airflow. This is sometimes referred to as there's a couple laws or equations that we're going to use to help characterize airflow. These are not equations you need to memorize, but just understand the concepts that we're talking about. Ohm's law, that you may remember from high school physics, describes the relationship between flow relative to the pressure gradient and the resistance. Flow, sometimes referred to as Q, is directly proportional to the pressure gradient, delta P, and inversely proportional to the resistance. This is the same thing for the relationship with electric currents, voltage, current, and resistance. Now that resistance is defined by what's called Poussey's law. We know that the resistance is directly proportional to the length of the tube, the viscosity of the gas or the liquid, but it's inversely proportional to the fourth power of radius. Now remember, because radius is being raised to the fourth power, it's the biggest determinant of resistance. Now remember we talked about the bronchial tree. As we go down and branch, the individual airways are getting smaller, but the total cross-sectional area is increasing. If the resistance was dependent on airflow just through one of those airways, we would expect the resistance to increase as we go down the bronchial tree. But that's not actually the case. The reason for that is because the resistance is a property of the airways in parallel, not in series. So in other words, it's the resistance defined by the radius of the total cross-sectional area that the air is flowing through. As we go down distally in the lungs, the total cross-sectional area is increasing, so the resistance is going down as we go to distally in the lung. Unfortunately, many different questions will address this in different ways, and they'll ask, for example, what the area of most resistance is in the lungs. Some questions might say the large airways, some questions may say the medium airways. The important part of this is whether it's the large or the medium airways, it's not the small airways. The small airways, despite their small radius, contribute very little to airway resistance. And for this reason, they're sometimes called the silent zone of the lungs. So if you have a pathological process in the small airways, so if we have a problem with resistance, why not just breathe harder? Why not just increase the pressure gradient so more air flows? There's a couple different problems with that. As we increase the delta P, or the pressure difference between the two, we're increasing the pressure in the thorax. And not only are we increasing the delta P, we're actually increasing the pressure around the airways. This creates a process known as dynamic airway collapse. So the harder you try, the more you collapse airways. When you collapse those airways, there's some air that gets trapped behind. That trapped air is what's contributing to the hyperinflation that we see in obstructive lung diseases. This diagram shows that as we're increasing the delta P, as we're increasing our intrathoracic pressure, not only are we trying to create a pressure gradient that gets air from inside our chest outside our chest, we're actually increasing the pressure on those small airways. So if we increase the pressure enough, we'll actually close off our airways. This dynamic airway collapse is what leads to the relative inflexibility of the flow volume loop curve, that we can never overcome the descending limb of the flow volume curve that we showed in the section on spirometry. There are factors that we manipulate to try to increase our airflow. Going back to Poussey's law, viscosity was a component of resistance. Viscosity is obviously hard to change physiologically, but sometimes in the hospital we might try to adjust the viscosity. We can do this by giving heliox, or helium-oxygen mixture, which is lighter than regular air and is going to decrease the viscosity and therefore decrease the airway resistance. But the biggest way we do this is by giving pharmacologic agents. They're going to adjust the radius of the bronchial tubes. We want to give bronchodilators that would increase the radius of the bronchial tubes. There's another adaptation that our body makes. People with obstructive lung diseases, remember, are breathing at higher lung volumes. They've got higher total lung capacity, they've got higher residual volume. At higher lung volumes, while the lungs are bigger, the airways are actually bigger as well. For example, if you took a deep breath in, you would expect that each of your individual airways, the radius would increase just a little bit. In that case, the hyperinflation is actually somewhat adaptive. That hyperinflation causes an increased radius, which causes less resistance, helps overcome the resistance that we're having a problem with in our obstructive diseases. Pharmacologically, we manipulate this by giving sympathetic stimulants, such as beta-2 agonists like albuterol or salmeterol, or by giving parasympathetic antagonists or anticholinergics such as ipratropium or tiotropium. Tiotropium is just the long-acting version. Both of these are going to lead to bronchodilation, either directly by stimulating the beta-2 receptors or by inhibiting the parasympathetic mediated bronchoconstriction. Another big problem in obstructive diseases such as asthma or COPD is inflammation. Because there's inflammatory cells, because there's inflammatory cytokines, we see swelling of the airways. So some of our pharmacologic agents are specifically want to address this inflammation. We'll give inhaled or oral systemic corticosteroids. We can also give leukotriene antagonists such as montelukast or Singulair. Now remember, these interventions take time to work. They're not working directly via stimulating or blocking a nerve. They're going to take time. Those bronchodilators, those inhaled agents like albuterol or like ipratropium are going to work much quicker. Summarizing some points in airflow. Remember, the flow is directly related to the pressure gradient. It's inversely related to the resistance from Ohm's law. The airway resistance is determined by Poussin's law. And the most important thing about that, the most important component of that is the radius of the airway. So if we want to change the resistance, the best thing we can do is change the radius of the airways. Obstructive diseases are diseases of exhalation. Here's a question that covers some of this. An 18-year-old is admitted to the hospital with an asthma attack. Compared to her baseline, which of the following would be expected to be increased during the attack? The correct answer here is C. We would expect her residual volume to be increased. FEV1 to FVC ratio would all go down. Her arterial PO2, the amount of oxygen is carried in her blood, could be normal or it could be decreased, but I wouldn't expect it to be increased. Continuing in pulmonary mechanics, we're going to talk a little bit about the respiratory system as a whole. And for this, I'd like you to think about the lungs the way you think about a balloon. As we inhale, we blow the balloon up. As we exhale, the balloon collapses down. There are forces that are going to help, quote, blow the balloon up. These forces are sometimes referred to as transmural pressures. These are opposed by forces that want to collapse the balloon down, sometimes referred to as elastic recoil pressures. The transmural, the extending or blowing up forces, can be increased either by raising the internal pressure relative to the external pressure. This is what happens when we give mouth-to-mouth resuscitation or we put somebody on positive pressure ventilation, as in the ICU. We push air into their lungs to increase the lung volume to blow up the balloon. It can also be accomplished by decreasing the external pressure relative to the internal pressure, by creating negative pleural pressure. This is what we do when we breathe normally. We contract our diaphragm, get negative pressure within our chest. That negative pressure in our chest is lower than the atmospheric pressure, and therefore air flows in. This is also how an iron lung works, an old form of a ventilator. If you imagine, if you had lungs just sitting, in the physiology lab, you could look at how much pressure it took to increase the lung volume. This is sometimes referred to as the static lung pressure volume curve. I know, it's another example of a graph. It's easily confusing. But this is actually very simple. Just imagine you had a set of lungs that you were experimenting on. You could look at how much pressure it would take to increase the lungs from residual volume, with no gas in them, all the way up to total lung capacity, where they're full. This curve, the amount of pressure that it takes to get to a certain lung volume, is the compliance curve for the lung, and a very important point. Compliance is the change in volume over the change in pressure. Normal value of compliance is about 80 cubic centimeters per centimeter of water. But it's not really important to remember what the normal value is. It's more important to remember what we're talking about with compliance. The opposite of compliance is what's called elastance. This is just 1 over the compliance. So you can think about compliance as how easy the lungs are to blow up, and elastance is how much the lungs want to snap back. So for example, if something's got a very, very low compliance, it's very, very hard to blow up, we would expect that to have a very, very high elastance. Imagine a thick, heavy rubber balloon. The opposite of that would be something with a very, very a very, very high compliance. This would be a very, very flimsy balloon. It's very easy to blow up. It's got a high compliance, but the other side of that is it would have a low elastance. It wouldn't want to collapse down as much. What determines what kind of balloon you have is a function of the lung internal connective tissue, and will directly determine what the functional residual capacity is that we're going to talk about in the next section. The compliance curve is nonlinear. It's an important point. As we go to higher and higher lung volumes, it takes greater and greater pressures to increase the volume. So for example, the lung is very, very compliant at low lung volumes, but when we get up to high lung volumes, when we take a deep breath, it becomes harder to get more air in. The compliance curve can be drawn for 3 different pathological conditions. For example, in the case of emphysema, shown on this slide, emphysema is an example of a very, very high compliance lung. It's also a very low elastance lung. It takes very little pressure change to get a big change in volume. We see the normal curve as before, and then we see a lung in the case of fibrosis or interstitial fibrosis, or you might see this also in acute respiratory distress syndrome, where the compliance is low. It takes a very big change in pressure to produce the same change in volume. I want to bring up the important point that for each of these lungs, the compliance curve is not linear. So for the emphysematous lung, the normal lung, and the fibrotic lung, the compliance is lower as we go to higher and higher lung volumes. But each of these curves represent different starting points. Let's compare this. Stiff lungs, low compliance, high elastance. Examples of this would be pulmonary fibrosis or ARDS. You need a big pressure to get the same change in volume. You've got a thick, heavy rubber, tough to blow up balloon. Contrast this with very compliant lungs that have high compliance and low elastance. And the good example of this is emphysema. With emphysema, you've got a lot of loss of the internal connective tissue. And this loss creates to a loss of what's creating the elastic recoil pressures. This is a thin, flimsy balloon. Now, I don't want to totally make the distinction that all stiff lungs are restrictive and all compliant lungs are obstructive. Really, the only compliant lung is the emphysematous lung, the lung that has a loss of alveoli and a loss of the internal connective tissue. It's not as easy as obstructive and restrictive going with each of these. In the next section, we'll talk about how the balance of compliance and elastance determine the functional residual capacity, which is a key lung volume. That concludes our discussion of airflow, and we've introduced the whole concept of pulmonary mechanics. We're going to continue that in the next section.